So please join me to welcome Dr. Miller for his presentations, Best Practices, Bright Future, Antimicrobial Stewardship in Pediatrics.
Thank you. Awesome. Well, I hope everyone's had a great morning so far. Today, I'm going to cover a wide breadth of pediatric antimicrobial stewardship topics, kind of not diving super deep into each, but really scratching the surface on some opportunities to improve antibiotic practices in our youngest and tiniest patient population. So with that, we'll kind of get going. Um, So for today's talk, I have no relevant financial disclosures. And then listed here are some objectives that we'll attempt to cover today. And hopefully at the end of this, you'll be able to recognize various opportunities and recommend up-to-date evidence-based antimicrobial optimization practices if you encounter our pediatric population in your facility. And so just a little bit brief, I'm sure this has come up in various talks and understanding what is antimicrobial stewardship, but antimicrobial stewardship is really a multidisciplinary effort to improve antibiotic uh, outcomes with regard to selecting the correct antibiotic at the correct dose, using the best route available, and for the right duration. And through all of these things, we can improve patient outcomes, decrease antibiotic-related adverse events, including the development of resistance and C. difficile infections, as well as individual safety outcomes related to the antibiotic itself, and then also decrease cost and waste. So it takes a village. So this just highlights our antimicrobial stewardship program at Children's Hospital. There's a lot of us across the continuum from pharmacy, from our ID division, from our hospital medicine and surgical groups, our microbiology lab, our informatics, our patient safety, PK/PD, infection prevention and control. So we really are very blessed to have such a big group invested in antimicrobial stewardship at University of Colorado, and we definitely have Dr. Sarah Parker to thank for all of that work that she did to develop and grow this program over many years. So with that, there are different models for conducting stewardship, most of which centers around a prospective audit with feedback. There are kind of the traditional audit feedback, which includes kind of contacting teams via different mechanisms. This could be calling, paging if still using pagers. If you're on Epic or other electronic medical records, there might be an electronic way to chat the team with your recommendation. And then there's also handshake stewardship, which really pioneered by Dr. Parker, which is in person, face-to-face rounds with the teams every day. And we review all antibiotics 7 days a week. We're fortunate to have antimicrobial stewardship pharmacists coverage 7 days a week. So we run the list every day, Monday through Friday. We have a physician that also runs half the list with us, and we kind of alternate who's taking which list. So we review at two different time points, the initial 24 hours of prescribing, and then again at kind of a 48 to 72 hour time point to review once there's more information available and maybe susceptibilities and whatnot to guide like targeting therapy or discontinuing therapy if an infection has not been identified that could be helped by antibiotics. And then we review positive blood cultures and things like that. And so once we review these and put them on a rounding list, then we go around and basically walk around and find every team. And we really try and highlight finding each team. So it's not that we're just coming to them when there's a recommendation or an issue, but we're really fostering that like collaborative relationship and giving them an opportunity to ask us questions, even if we don't have anything for them. And it feels good for them because they're like, oh no, what did I do? And we're like, you didn't do anything. You're doing really well. We didn't have anything, but we just wanted the opportunity to ask if you have questions for us. And sometimes that could just be educational topics as well. So we do a lot of kind of in real-time education when the teams have questions about something that has come up related to a patient or a recent situation. Through this, have decreased been able to sustain a significant decrease in our antibiotic prescribing practices, which has translated to significant cost savings as well as increased ID consults. And this just kind of highlights some of the work that Christine McBrain and some of our informaticists, Kelly and Megan, have helped us put together over time to see our sustained improvement in antibiotic DOT. So just to highlight that before we get into more of the clinical aspect of how you can identify opportunities for stewardship in your patient populations when dealing with pediatrics. So first off is the big three. These really encompass the vast majority of infections that we see, both inpatient and outpatient in children, which also mirror what you typically see in the adult population as well in terms of community-acquired pneumonia, UTI, and skin soft tissue infection. So looking at the etiology of community-acquired pneumonia, the MYSTIC study looked at children admitted to hospitals around the country to try and identify what are the most common causes of pediatric community-acquired pneumonia. And no surprise, much like the adults, viruses are the number one cause. And viruses don't care if you give an antibiotic, they get better on their own for the most case. But it's also very hard to discern viral from bacterial pneumonia. Pneumonia is a clinical diagnosis. So in that, a lot of patients end up on antibiotics for hospitalized pneumonia. And so we really have to try and target maybe not as much on the decreasing starting antibiotics, but really tailoring to the shortest effective duration and the narrower spectrum that is available to us to treat the infection. So among bacterial pneumonia in children, strep pneumoniae is really the most common cause. Mycoplasma is also up there, but we'll talk about that a little bit later, and generally self-limiting and questionable benefit from directed therapy for Mycoplasma pneumonia. Amongst strep pneumoniae, in the US, penicillin susceptibility rates are exceptionally high, around 97, 98% when looking at the Century database for US strep pneumonia isolates in children. So with that, our first-line therapy for hospitalized children with non-severe uncomplicated CAP is AMP or amoxicillin. We actually don't have a preference. Some children get admitted based on their clinical status, but they're able to take PO and amoxicillin achieves really good levels. And so we just start them right out on amox and observe them and see how they do. And that way they can go home and maybe not even get any IV therapy. For those who are allergic or have more severe pneumonia on presentation, such as they're going to the intensive care unit, we might start with ceftriaxone to be a little bit broader and encompass some of those other causes. Depending on your local prevalence of Staph aureus and methicillin-resistant Staph aureus in particular, that empiric coverage for a more sick patient might be augmented somewhat to include MRSA active therapy. H-flu is also in there, but pretty rare in the post-Hib era. And so we really don't have a lot of invasive type B Haemophilus. Vaccine rates are declining, so it'll be interesting what happens over time. But hopefully there's still enough herd immunity that we continue to have low prevalence of invasive type B in Haemophilus infections. And with that, even 70 to 80% are ampicillin susceptible. So we can often get away with AMP or amox alone, given that non-typable are generally self-limiting and you're covering most of them. So we generally do AMP and amox or ceftriaxone as our empiric therapy. Some other common questions that kind of spin off of this is what to do about mycoplasma or aspiration pneumonia. And so for mycoplasma, like I alluded to, it's a self-limiting pneumonia, the cause of walking pneumonia. And so these infections can kind of mimic a lot of different presentations. Often clinicians will have kind of a classic, this looks atypical, but when you look at the literature, mycoplasma pneumonia can look like any other pneumonia. And so even the best clinicians using imaging appearance and clinical presentation are right about 40, 50% of the time. And so atypical pneumonia is just very difficult and often And again, we're not actually sure that antibiotics help these. In terms of testing diagnostics, serologies are often very unreliable and not recommended. PCR has improved sensitivity, particularly for the oropharyngeal site. If you have access to that, it's also mycoplasma as a target on the um, BioFire respiratory upper respiratory panel. So that could be a tool used to treat or not treat in those situations. Nasopharyngeal sources are maybe a little bit less sensitive than oropharyngeal sites for mycoplasma. The downside to this is the specificity of that target is a little bit lower because you can have persistent detection of mycoplasma for months after the initial infection. So you kind of have to weigh that with selection. And so just highlighting that a lot of this comes from Dr. Parker. And she's given some really exceptional talks on mycoplasma, so it could be its own talk. But who to treat? So I think there are different ways you could look at this. You could treat everyone coming in with empiric atypical coverage, which is kind of often the case in adult populations based on the CAP guidelines, recommending like a beta-lactam plus macrolide or doxycycline to empirically cover for mycoplasma and other atypical organisms. However, most of the data is very unclear about the actual benefit of treatment, potentially limiting the duration of symptoms by less than a day, and not really changing the overall outcomes in terms of length of hospital stay, progression of illness, or ultimately mortality. These are, again, very rare outcomes for mycoplasma pneumonia. So really the clinical benefit of treating it is unclear. And so it's for any benefit, the number needed to treat is probably super high. So you end up over treating a lot of patients for a very minimal gain, and that's a lot of excessive antibiotic exposure. And you might say, well, it's just azithromycin, it's already resistant, and so it's not a big deal. But azithromycin has lots of side effects in a pediatric population. In particular, it's been linked to increased risk for childhood obesity. And so we really like to not treat everyone with an empiric macrolide and really target those who are maybe not improving despite antibiotics and who are just kind of like stalled out in their clinical progress after targeting like usual causes of community-acquired pneumonia like strep pneumoniae. And in those situations, to consider testing if it's available to you. It might be more limited in an outpatient setting, but if you're inpatient and you have that testing, that could help guide, like if you detect it and they fit the clinical picture, then considering to treat that patient as opposed to treating everyone. So then moving on in a little bit into aspiration pneumonia, this is those without abscess or empyema. So just kind of what most of us probably run across is actually chemical irritation or pneumonitis and not true infection. With that, the adult guidelines do not no longer recommend adding anaerobic coverage for patients with straightforward aspiration pneumonia without abscess or empyema. And for most of these, it's oropharyngeal organisms. And so we do have some oral anaerobes, but fortunately, a lot of them are actually very penicillin susceptible. So we generally recommend in those cases just doing AMP and a MOX and try and limit the duration to 5 to 7 days in most cases, and not add on the beta-lactamase inhibitor. And if you're pen allergic, then ceftriaxone also covers a lot of these bugs pretty well too. And so we don't necessarily need to add metronidazole or clindamycin to the ceftriaxone to add on any oral anaerobic coverage. What about oral transition? So really highlighting the good, the bad, the ugly of these. If any of you are kind of from pediatrics or pharmacists, you probably know that we do not like ceftonir. It's a very poor PK drug. It has very limited bioavailability and it has high protein binding. So again, your pharmacodynamic target attainment is much poorer. So looking at this and with the help of Andrew Haynes, who's one of our physician stewardship champions that focus in PKPD, and really loves oral PKPD like beta-lactams and has done a lot of work with cephalexin, cefadroxil, in our MSK and neonatal population, put this together and just really highlights that a MOX is really superior in terms of your likelihood of achieving your pharmacodynamic target with oral because of its high bioavailability and the frequency of dosing. TID slightly better than BID, which is what we generally do for community-acquired pneumonia. For otitis media, you have like sustained inner ear concentrations of a MOX, and so you can get away with BID dosing a lot better. But really for targeting potentially those higher end of the MIC range for a MOX, we generally do TID for strep pneumo in the setting of community-acquired pneumonia. And then when you look at your oral cephs, really cefprozil, cefuroxime, cefpodoxime are a decent step down from amoxicillin when you look at their ability to hit pharmacodynamic target for strep pneumo. And then Cefixime and Ceftonir are pretty poor there. So just highlighting not all oral cephs are created equal and still are probably inferior to amoxicillin. And so really promotes in kids with allergies, really getting them delabeled so that they can be on the best therapy moving forward. We do have a really good delabeling pathway locally, given all the literature about penicillin allergies out there. In terms of best duration, the 2011 pediatric pneumonia guidelines recommend 10 days. However, we've had lots of randomized controlled studies at this point, as well as retrospective observational studies to say 3 to 5 days is just as good as longer courses. I would say the caveat with a 3-day group is be cautious that some of these might have been heavily viral pneumonia and so we have not quite adopted the 3-day course ourselves and still stick with 5 days for most community-acquired bacterial pneumonia. That being said, with the vast majority of these being viral and no benefit of antibiotics, there probably is some role if antibiotics are initiated and the patient is clinically improving very rapidly, that 3 days might be fine in most like low risk, mild to moderate cap. But 5 days is generally the preferred durations at this point. And when you look at the evidence for short course, it's been shown to be less costly, associated with less adverse events. There was a really good study by Pranita Tama's group who did for each additional day of antibiotic in children, the risk of developing a side effect is about 7%. And when you look overall at antibiotic prescriptions in children, about 30% of them will have some adverse effect from their antibiotic. So really highlighting being judicious with antibiotic prescribing and limiting the course to avoid side effects. And then they've shown lower resistance and then also fewer days caregivers are absent for work, which is, I think, really important for parents to not have to miss work and be able to kind of return to that. And then moving on into UTI considerations. So looking at the way urine is collected in children, I think is something that was a little bit news to me, and thinking about like whether or not the child is toilet trained and ability to actually give a reliable clean catch. And if not, then how do you collect a urine sample cleanly so that it avoids contamination? The historic gold standard was suprapubic aspiration, but nobody wants to stick a needle in a kid. And so this has really moved to straight catheterization as kind of the standard of care for collecting urine samples sterilely and like diapered and non-toilet trained children, usually under like 2 to 3 years of age. Clean catch has a bit higher contamination risk. And then bag specimen or pads where they basically put a bag around to catch the urine. It also goes around and potentially gets contaminated by stool in that. And so this method is less reliable, and you can see contamination anywhere from 30 to 60%, which is similar to pads, because again, the GU tract and the GI tract are in such close proximity that there is mixing there. And so you have to be cautious with interpreting those specimens. And so when looking at the data for some kind of ways to approach this and reflected in our UTI pathway as well as other pediatric centers is whether or not antibiotics are indicated right off the bat. If they are, then we generally go to like UA and straight cath and culture from a straight cast specimen, as opposed to like if antibiotics are not immediately indicated, then we might do a screening UA from a bag specimen to avoid instrumenting the child. However, if the UA is positive from that, we wouldn't want to do a culture because there's a high risk of contamination, and then the positive predictive value is pretty poor from the bag specimen. The negative predictive value from the UA is still pretty high. And so if the UA is negative, then you can kind of generally stop there in most cases. But if you are going to pursue a urinary tract infection workup, then the recommendation would be to get a straight cath for a repeat UA and culture. So, and University of Pittsburgh put together a really helpful calculator tool for children 2 to 23 months. It's UTI Calc at University of Pittsburgh, and you can go online and it helps you with initial assessment to determine what the risk of UTI in the child is based on their age and symptoms. Based on that, it'll say your pretest probability of UTI is high enough that you should probably send a UA and culture. And then you can refine your probability of UTI with the UA results. And once you plug that in, it's like, it's less than 5%. It's probably not a UTI. And so you may not need to actually treat in this instance. And important to highlight the changing epidemiology with regard to empiric selection. And so you can see here from the Century database from 2013 to 2023 that overall E. coli and Cleb are increasing in ceftriaxone resistance nationally in children. And that is it has been most common in our under 2 years of age, as you can see from the graph on the right. So think about risk factors, local resistance patterns, and severity of illness to determine whether or not empiric therapy should be escalated in a particular child who's at increased risk of ESBL, because we're definitely seeing an increase in this over time and approaching kind of adult levels of resistance in our pediatric patients, which is unfortunate. In terms of interpreting susceptibilities, I wanted to highlight that CLSI now has 2 different breakpoints, so it's really important to know that these are there and how your microlab handles these, because it can guide you correctly or incorrectly to oral step-down therapy. And knowing that the breakpoint for systemic infections is 2, but for lower urinary tracts such as cystitis, the breakpoint is 16 because a lot of our oral cephalosporins, as well as IV cefazolin, concentrate heavily in the urine. So you're actually able to overcome these higher MIC bugs when just treating a localized like bladder infection. So this is the cystitis interpretation, which also infers to cephalexin, cefuroxime, cefpodoxime. And then a recent publication from Dr. Haynes here looking at dosing to achieve a 50% time over MIC in our neonates and young infants, really highlighting above kind of the first month of life, we need to be doing more Q6 to hit these pharmacodynamic targets when the cefazolin MIC is less than or equal to 2, but when it's less than or equal to 16, the cephalexin MICs can actually be 8 to greater than 16. And so with that, higher dosing than we typically give would be indicated. And so this just highlights that in these cases, it might be best to avoid cephalexin if you're treating like pyelonephritis or bacteremia, because the ability to achieve your pharmacodynamic target may be much harder, requiring much higher doses, which may incur more side effects. So in terms of how long to treat UTIs, there's actually not as much pediatric specific data. Sorry, I think I got there. Oh yeah, okay. And so we have a couple of studies in children, but maybe not as much as there is on the adult end. So there was this first study, which was a retrospective large cohort study of children 6 months to 18 years. And they compared short course, which was anywhere from 6 to 9 days versus 10 days or longer in children diagnosed with pyelonephritis. And no surprise, they didn't find that there was a huge difference between short course and long course in terms of treatment failure. And then recently we did have the Scout UTI trial, which was a randomized controlled trial of children 2 months to 10 years who presented to the ED with UTI symptoms and were diagnosed with urinary tract infections. They looked at short course being 5 days. And so children who were doing well at 5 days were either prescribed placebo for another 5 days or 5 more days of antibiotics. Um, and then their primary endpoint was symptomatic recurrence at kind of the day 6 to 14 visit. And so it actually was not non-inferior with a slightly more treatment failures being documented in the short course. However, when you look at like the number needed to treat for symptomatic recurrence and the additional antibiotic days, most of us feel that 5 to 7 days is still worth the small number of failures, because in order to prevent those failures, we'd have to expose to an extra 140 antibiotic days to see that benefit, and likely it's not worth it in those instances from other outcomes. So we still recommend 5 to 7 days, and in that case. So febrile UTI in children under 2, because they're nonverbal, you can't really tell that it's pyelo or not. And so we often treat them as if they have pyelo for febrile UTI. And so 5 to 7 days is the general recommendation for febrile UTI in children under 2. And then for children over 2 who you can clearly establish whether it's pyelo or cystitis, we generally follow the adult recommendations of 7 days for pyelo and 3 to 5 days for cystitis. And then kind of bringing in a little bit of myth busting here, cellulitis. So the first is Bactrim. So I think the historic lore myth that I remember being taught is it does not cover group A strep. This is incorrect. And really stems from a problem with the historic testing media and unregulated thymidine content. Thymidine is an escape mechanism, so that overcomes the folate antagonism pathway with Bactrim. And so when you limit the thymidine content in testing media, group A strep in the US and Europe is 99% susceptible to Bactrim. And so what about clinical support? There's a lot of discussion saying that, well, thymidine might be present at the site of infection, and so bacteria might be able to scavenge that and overcome Bactrim in clinical context. And there is RCT in ED populations, including adult and children, that looked at Clinda versus Bactrim. In the subgroup of cellulitis without abscess, which would be our typical like non-purulent cellulitis that we're most suspicious for group A strep, cure was 91% in Clinda and 87% with Bactrim. So again, highlighting that like clinically and testing Bactrim does work for group A strep. And that is a myth and should not be perpetuated. And then the second myth is doxy on whether or not it's safe in children under 8 because of teeth staining. We're all taught this. It's a package insert warning. What's the literature? Doxy, as well as Minnow, actually have very low risk for teeth staining. They do not chelate calcium the same way as tetracycline and chlorotetracycline and oxytetracycline of old. The Red Book, which is our ID Bible in the pediatric side, says you don't have to consider age or duration of treatment as a contraindication for doxycycline. Use as you will. And the evidence really stems from the Indian Health Service group, who did a study looking at children who got doxy for Rocky Mountain spotted fever and did before the age of 8. And then they had blinded dentists look at their teeth and that versus a control group and doing teeth shading and various outcomes. There was no difference identified between kids who received doxy before the age of 8 and children who never received doxy. So myth busted. Doxy is safe in children. In terms of cellulitis dosing and duration, so cephalexin dosing, do you do QID versus TID? What about cefadroxil? Some people might not have heard of that drug. And so back to Andrew, because he does a lot of work with these drugs. And so highlighting his work here in older children with musculoskeletal infections, he gave them either a single dose of cephalexin or cefadroxil and looked at the PK and then developed a model and did Monte Carlo simulation across various weight ranges and found that really your cumulative fraction of response across the MSSA, MICs. So generally MICs from 1 to 4, a few 8s in there, but very few, which is why the CFR is so high. You can see here that like TID dosing achieves, 98 to 100% cumulative fraction of response across the continuum. And so TID is much easier and more convenient for parents and children to dose than QID dosing. And so we've since moved over to TID dosing recommendations. And then for cefadroxil, because of its kind of delayed absorption effect, it has a longer Tmax. And so with that and a slightly slower clearance, it spends more time above the MIC. So you're actually able to get it down to BID dosing with a high percent chance that you're going to hit your pharmacodynamic targets. So another option, although would say slightly more GI side effects, particularly at the upper end of dosing with cefadroxil versus cephalexin. Cephalexin seems to be very well tolerated at the higher end of dosing, whereas cefadroxil seems to have a little bit more dose-dependent nausea and vomiting associated with it. Although I've heard that if you can get them past the first 2 or 3 days, that generally subsides and goes away. So, all right. Uncomplicated bacteremia, how long to treat? There's really not as much pediatrics. Oh, sorry, this is repeat blood cultures. So this is similar to adults. The question is like, do you need to repeat cultures every time? This came up recently with our blood culture bottle shortage. And so can we be stewards of our testing supplies? And this study would also highlight, similar to adults, that the utility of repeat blood cultures is maybe limited to certain patients and certain bugs. And so really highlighting that you should generally consider always repeating for like Staph aureus, Pseudomonas, Candida, and those with a central line present or ongoing clinical instability is also another consideration. They also found that some of the other non-fermenting gram-negative rods might have also had a higher chance of having persistent positive blood cultures. But then there's a lot of patients that we probably don't need to repeat. Again, only 17% had persistent positive cultures. So there's a lot of opportunity to not poke for repeat blood cultures without any risk of safety or missing a persistent bacteremia. And then what is the optimal duration? And so there's numerous RCTs in adults that say 7 is equal to 14 in most uncomplicated gram-negative and gram-positive, excluding Staph aureus from that equation. What about pediatrics? Well, there's one retrospective study with small number of patients, 31 in total, 16 in the short group, which was 7 to 10 days, and 15 in the longer group. And there was no recurrences reported from this small cohort. We attempted to do a local study here and highlighting our past ID resident Amanda's work, who's now faculty at University of Georgia, and looking overall reinitiation of antibiotics within 3 days, infection recurrence at 30 days, and all-cause mortality within 60 days was not significantly different across the groups. The one death was unrelated to infection and was due to a omphasil rupture, and so unrelated but reported here. She did DOR analysis, which is a desirability of outcome ranking to factor in risk of safety and emergence of resistance to try and see if short course were just underpowered, really. But you'll see some of those none of those are really favoring one versus the other. We're ongoing looking to at least get more short course patients into this so that we can rerun the analysis with more power to detect any differences. So, but just wanted to highlight that. And then what about central lines? And different from adults where I feel like we often just said, remove the catheter, treat, and it's good. The stakes of removing lines are a lot higher in children, particularly our digestive health children who are TPN dependent. The more we remove the lines, the more we limit their future vascular access. And if they can't feed them, then their risk of death increases. And so we really try and salvage catheters when we can. And with that, should we be treating longer? I would say the data highlighting failure is actually showing that failure is not as common once you achieve initial clearance, and those with persistent positive cultures often just require the line to be pulled. But if we can get their blood to clear, then there's a lower chance of recurrence, usually within about 10%, with the exception of Canada, which has a very high recurrence rate. Even Staph aureus, interestingly, has a low recurrence. The risk of them having persistent bacteremia, though, is that you might seed other places throughout their body. So we have a very low threshold to pull catheters for Staph aureus when it's persistent. But for something like coagnic staph, we kind of will monitor their clinical status and try and treat through as much as we can. But if it looks futile, then we go ahead and remove the catheter. Once we achieve clearance, though, there's really not good data to say that the duration of antibiotics prevents recurrence. And there's limited data to suggest that, like, whether or not you treated them for more than 10 days or less than 10 days, that their risk of relapsed bacteremia was any different. And so we've moved towards 7 to 10 days once clearance is achieved if there's no complications for our central line bacteremia salvage patients. And then the question of ID consult comes up, and there's really good literature on the adult side. I came across one pediatric paper suggesting that, like, achievement of key quality metrics for Staph aureus bacteremia, such as repeat cultures, consideration of echo, targeted antibiotic therapy was significantly improved in the ID consult versus the not ID consult. And patients who achieved those quality metrics were more likely to have optimal outcomes compared to those who did not fit into those quality metrics. When they looked at just ID consult, there wasn't a significant difference, although there was a trend towards better outcomes with those patients who had ID consult. So if anything, similar to adults, ID consult's important for children who have Staph aureus bacteremia. And then enteral transitions in bacteremia, I would say there's much more limited pediatric specific data on this. Supportive evidence has mostly been demonstrated in musculoskeletal infections, highlighting that in patients who are clinically improving, have source control, clear their blood cultures, and have declining inflammatory markers, that usually we can switch them to oral and complete their duration with oral therapy that includes cephalexin for MSSA. And we usually end up switching to oral in most cases within the first 2 to 3 days, and they do very well. And then historically, occult pneumococcal bacteremia. But what about uncomplicated gram-negative and other gram-positive bacteremia, excluding Staph aureus? There's a lot of data in the adult side, and we kind of extrapolate from this, saying that, you know, highly bioavailable options with uncomplicated source of infection, we're likely to achieve a good outcome in most of these. And so just highlighting some of the adult data to support this, but we don't have as much pediatric data, but we do extrapolate and generally switch a lot of our uncomplicated bacteremias to oral. Considering some of these criteria, which are probably not new to a lot of folks and make clinical sense when you think about them. So what about our neonates? And so first thing to talk about is they end up getting a lot of sepsis rollouts. Babies are unpredictable. It's very hard to know if they're sick or not. And so, and we don't trust babies. And so oftentimes they look at you funny. We get started on a rollout for neonatal sepsis. And there's this is probably the most frequent indication for antibiotics in our tiniest population. The traditional duration is 48 hours, but a local QI project led by Christine McBrain and Sarah Parker led to an updated recommendation to shorten that to 24 to 36 hours. And when we looked at time to positive blood cultures, which is often why we wait the 48 hours to make sure, like, our cultures are negative and they're doing better. But if they're doing better and their cultures are negative at 24 hours, greater than 90% of them would not go on to grow any bacteria, and 24 hours is usually a pretty good marker that they're not going to have positive blood cultures So prolonged antibiotics have been associated with increased necrotizing enterocolitis, length of stay, and death in our neonatal population. So we want to try and expose them to the least amount of antibiotics that's safe. So considering shortening that rollout time frame. And then what about culture negative sepsis? Generally speaking, 7 days is kind of the classic duration, but there's good data now that says anywhere from kind of 2 to 5 days, if you've rolled out everything, is probably just as good. We generally do 5 days for our culture negative sepsis courses. And so there's supportive literature for shortening the duration of in your culture negative sepsis when you're decided to go ahead and treat them for a course. What about oral antibiotics? I think we just treat IV for our neonatal patients with an established infection, bacteremia, UTI. Clearly, bacterial meningitis and HSV infection should be treated with IV therapy. But what about uncomplicated infections when those more complex situations have been rolled out with testing? There's still a precedent to treat with IV therapy because we think babies don't absorb things as well, and their gut doesn't have as mature transporters. There's really not supportive data of that. I think it's kind of historic lore that babies don't absorb super well, and there's much emerging evidence that shorter IV courses with enteral transition and uncomplicated situations does not end up with worse outcomes. So this is just highlighting some of those studies and really suggesting that like shorter IV courses with transition to oral was just as good as continued IV duration. So drugs that have good PK data in our young infants and that we generally recommend when we're transitioning to enteral therapy include Amox, plus or minus clavulanate, cephalexin, trimethoprim sulfa. There is a reported warning for children under 2 months of age with Bactrim. However, this is extrapolated from sulfasalxazole kernicterus, and when you look at sulfamethoxazole specifically, has a very low risk of bilirubin displacement from plasma proteins, and you would really have to give exceptionally high doses of Bactrim to do this. And so, in most cases, as long as they have low bilirubin, usually less than 10, we're generally comfortable using oral Bactrim in them when they're under 2 months of age. Oh. Now, getting into transitions of care. So important stage and opportunity for antibiotic stewardship is, they leave our walls and now, it's the Wild West. People can kind of prescribe what they want. And so this is just highlighting some recent and important work with pharmacist review of antibiotic discharge antibiotics and showing a decrease anywhere from like 37 to 60% in inappropriate antibiotic use on discharge, namely around like spectrum and duration of therapy. Sometimes people forgetting to add in like the 3 days of inpatient antibiotics that they might have already gotten and sending them out on an additional 7 or 5 days, which might be more than they need. And so there's a lot of opportunity here. So as well as end dates on oral antibiotics, which is something that was implemented here. And so all of our oral antibiotics have a required end date. So when we transition, it also hopefully helps with that discharge transitions of care, such if they continue that order on discharge and Epic, that end date that's already been populated carries over to the prescription. Otitis media, this is highlighting some work of one of our past ID fellows who's now an ID attending here, and then her mentor, Nicole Poole, and then Joanna was the fellow at the time that implemented this project in our ED and urgent care related to an order set to shorten the duration and improve selection of amoxicillin as first line. So you can kind of see here the proportion of antibiotics prescribed didn't really change despite coaching to delay prescribing. However, defaulting the durations to 5 days for children under 2 led to a substantial improvement in 5 days being prescribed in that group. And then when we looked at amoxicillin prescriptions, there was kind of a big, it coincided with the amoxicillin shortage. And so the amoxicillin use actually dropped, but it was because we were recommending alternatives because we didn't have enough amoxicillin. But that has since kind of climbed back to pre-shortage baseline and continued to improve with first-line amoxicillin prescribing. What about ceftriaxone? So I think you'll see references say 1 to 3 doses for otitis media. Actually, the data is really good for a single dose, particularly in the post-pneumococcal conjugate vaccine era, where penicillin and ceftriaxone non-susceptible pneumococci is exceptionally rare. 1 dose of ceftriaxone maintains concentrations in the inner ear for 2 to 3 days, and so that's usually adequate to treat the vast majority of acute otitis media, and was not different than 10 days of oral antibiotics. You could consider, if you're going to repeat a dose, doing it at 48 hours if there's persistence and lack of significant improvement, but not needing to do that necessarily at the 24-hour mark because you still have good ceftriaxone levels in the middle ear fluid. For sinusitis, I think the guidelines suggest amoxiclav is recommended because of beta-lactamase and H-flu. However, H-flu has a very high spontaneous resolution for sinusitis as well as otitis, and so targeting it doesn't necessarily improve outcomes. This was a really good study from Tim Savage, looking at lots and lots of patients from a database and comparing amox to amoxiclav, and really finding that amox was not any different, with the exception of fewer side effects than amoxiclav. Amoxiclav causes a lot of diarrhea in our pediatric patients, and so amox being just as good for acute bacterial sinusitis, and then highlighting that 5 days is generally the recommended duration. What about group A strep pharyngitis? And so this really stems from, like, why do we treat group A strep pharyngitis? It's not to improve symptoms, because antibiotics improve symptoms by about 16 hours compared to no antibiotics. So probably not doing a whole lot there. Is it to prevent suppurative complications such as deep neck space infections, bacteremia, things like that? Those are rare. Those are about 1%. So really impossible to prove that antibiotics decrease suppurative complications. And when you look at 5 versus 10-day antibiotic trials in peds and adults, there's no difference between short course and prolonged courses in terms of suppurative complications. So this is really to prevent non-suppurative sequelae such as rheumatic fever and heart disease. However, that data is not the best because it comes from military recruits 75 years ago when they were using like parenteral IM penicillin mixed with olive oil. And if they suggested that 10 days was necessary to achieve eradication in this military recruits, their prevalence of rheumatic fever and heart disease was much higher. In the modern era, it's about 0.6 for every 100,000 will get rheumatic fever. And when you look at the number needed to treat with oral antibiotics to prevent 1 case of rheumatic fever in the United States, about 500,000. And really, there's good data for even a single dose of amoxicillin in achieving like over 90% eradication. So children, the AAP Red Book recommends that children can go back to school within 12 hours after taking their like amoxicillin dose, because it's a high rate of eradication. They didn't look at it at 10 days, so we don't have that kind of 10-day comparison to the old data for penicillin. So I would say in low risk areas and low endemic areas, the WHO actually recommends 5 days is just as good, and you can do that because the risk of rheumatic fever is so low that you wind up over-treating with an additional 5 days and in a lot of cases without clear benefit. So consider 5 days. There's actually some proponents that say consider 0 days, because again, we don't really see that it's probably impacting our risk of rheumatic fever. And if the kids are better already, then there's probably a low risk that it's going to actually help. And that gets into the last section, our immune compromised host. And so I'll kind of, with time, want to get through this a little bit. So evidence for fluoroquinolone prophylaxis really stems from this multi-center children's oncology group study that randomized our leukemic patients with 2 cycles of intensive chemotherapy, only 2 cycles, so important to note. And then the other group was children undergoing myeloablative auto or allo stem cell transplant. And then they did levofloxacin or no antibacterial prophylaxis. The results for their primary outcome was the incidence of bacteremia. And so levo was associated with fewer episodes of bacteremia compared to no levo in the leukemic non-transplant population. However, note that the baseline rate of bacteremia in the no-levo group was exceptionally high, 43%. That's much higher than previous studies had shown before. And so this really highlights an important question of like, if your baseline bacteremia rates were lower, is levo actually having that same substantial significant impact on risk of bacteremia? So important to highlight. When you look at the stem cell population, actually, there was no difference in the incidence of bacteremia, although febrile neutropenia was less. And then for secondary endpoints, in both groups, the number of febrile neutropenia episodes were lower, but hospitalizations, length of stay, and death from infection were not different between levo or no levo. So highlighting like what are the kind of important takeaway points, and really is the bacteremia different? Because again, 43% is exceptionally high. Not as hard to show a difference when it's that high. What are kind of the downstream consequences of levo prophylaxis? Well, this study looked at kind of pre-post implementation and highlighted that, you know, you're going to see more resistance if you put it in. And so patients are going at increased risk of developing levofloxacin non-susceptible gram-negative bacteremia. This next study highlights increased levo MICs over time for Verdans group strep and your immune compromised due to levofloxacin prophylaxis. And then this subsequent study for those who had fluoroquinolone resistant bacteremia, highlighting the potential for increased ICU admission and 30-day mortality. And this is likely not directly related, but indirectly related to fluoroquinolones not only cause resistance to themselves, but they can select for cross-class resistance due to efflux porin mutation mechanisms, which then can lead to resistance to your empiric first-line therapy, which may then delay appropriate coverage of an infection in a sick patient, which then increases risk of poor outcomes if you're missing the organism with your empiric coverage. So long-term impact, is it time to reconsider fluoroquinolone prophylaxis? So if you look at the EASL 8 guidelines, it's not actually recommended in pediatrics. It is recommended by the Children's Oncology Group guidelines. So just noting that there are differences of opinions and approaches on fluoroquinolone prophylaxis, and really highlighting that that study only studied the first 2 cycles of chemo. So we really at best only have benefit observed with the first 2 cycles, but in children who are getting more and more chemo, question of whether it continues to have benefit, particularly if you're selecting for resistant microbiota, and that does that kind of effect and benefit diminish over time if you're just recolonized with fluoroquinolone resistant gram negatives, and then is it kind of net neutral? Again, other outcomes such as hospitalization, length of stay, and mortality were not different. So is it a question of like, what's the most important outcome that we should evaluate in these situations? Bacteremia is important, but also in the context of like other factors. And again, noting the significantly higher bacteremia. There is no benefit observed in hematopoietic cell transplant population. And then again, is there a diminishing returns with ongoing fluoroquinolone prophylaxis over time with increased resistance? Is it also impacting our standard empiric antibiotic therapy? And with that, are we going to delay effective treatment in patients who are sick and increase morbidity and mortality from that? Side effects overall appear similar. Interestingly, C. difficile was higher in the non-fluoroquinolone group than the fluoroquinolone group, which kind of is shocking because we classically associate C. difficile infection with fluoroquinolones. And again, just highlighting is the effect diminished. So adult evidence would suggest this because they've been doing it a lot longer, and there's a lot of programs that are considering de-implementation of fluoroquinolone prophylaxis, and there's a lot of adult data out there highlighting the reversion of resistance after de-implementation of fluoroquinolone prophylaxis. A lot of that data is from our European colleagues. So just note that there's maybe some drive shift away from routine fluoroquinolone prophylaxis, and really highlighting like needing to look at your local epidemiology data and resistance to determine if it's the best course for your individual center. When empiric MRSA therapy is started, how soon should it be stopped? Vancomycin is often added for MRSA, intercocci if you're using a cephalosporin empirically, or resistant Viridans strep. Most guidelines would suggest stopping it at 48 hours if your cultures are negative. We reviewed our time to positivity data and found that on average for gram positives, it was around 13 hours, and 93% of our gram positive bacteremia was detected within 24 hours. So we've shifted our empiric vancomycin to be stopped at 24 hours. For those who developed bacteremia with a gram positive after 24 hours, 2 of them were strep mitis, which would have been covered by their empiric cefepime. One was an faecalis. As soon as the blood culture went positive, they started vancomycin, and the patient was stable at the time. And then one was granula catella, which should have been covered by their cefepime, but plus minus maybe a little bit more resistance there. But again, highlighting that, like looking at your time to positivity and really suggesting that you could maybe stop that earlier. And then the other debated topic is, should I continue the gram negative through neutrophil recovery in the absence of positive cultures? There's a lot of data on the adult side suggesting that it's safe to stop at 3 days, regardless of their neutrophil count, if they've been afebrile for 24 to 48 hours and their cultures and workup has been negative for bacterial infection. This is the recommendation in EASL 10 guidelines. It's considered less strongly by the EASL 8 pediatric section for FNN. And then in the pediatric studies, they really have not shown that there's a difference in fever recurrence, hospital admission, or antibiotic reinitiation when stopping soon. 2 studies to note here. One was in a population where they detected a respiratory virus and they were afebrile and for 48 hours and had received 2 to 3 days of IV antibiotics, and they either stopped or continued them on an oral antibiotic through 14 days or neutrophil recovery, whatever happened first. And again, resolution was not different, and there was no deaths. And in the 2000 trial, they gave 2 to 5 days of inpatient IV antibiotics, and if they were stable for 24 hours and had negative cultures and did not have sepsis, they either randomized them to placebo on discharge or oral antibiotics. And again, at hospital readmission was not different for placebo or continued antibiotics, and there was no deaths reported. So highlighting that is likely similarly in peds, we could consider stopping regardless of neutrophil count in that. And then the other question that I feel like comes up is, we have a defined bacterial infection. It's susceptible to narrower spectrum agents, but can we safely de-escalate from our empiric broad spectrum anti-pseudomonal drug, or do they need to stay on that because they had febrile neutropenia? And I think in the adults, it's more common practice to de-escalate. In pediatrics, oftentimes it's like, no, we need to keep on the cefepime, which is our kind of go-to empiric FNN drug. But this study was a nice study in pediatric ALL, AML, and looked at those with microbiologically detected bacteremia. Was 36 patients in total, and the average ANC was about 130 at the time. And those who were bacteremic who had antibiotic susceptibilities indicating it was possible to narrow or target their therapy, 18% did not get targeted therapy because they were too clinically unstable or had multiple positive cultures. Those who met criteria, like they were doing better, they were afebrile, and they had negative cultures, antibiotics were targeted in about 44%, and there was no fever or bacteremia recurrence. Again, small n to highlight, but suggests that we could safely target our coverage and move away from broad spectrum antibiotics in patients with microbiologically proven infections where we have susceptibility data to denote a narrower agent is available. And given time, I'm not going to go through all of these, just highlighting some new drugs that have been recently approved and whether or not they have pediatric specific data, but some potential oral options for some of our more resistant urinary tract infections that might be helpful. And then if you are seeing metallo-beta-lactamase producers, as Trio, Avi, or Imblavio is also now commercially available, although no pediatric ongoing phase 2 trials, and they do have allometrically scaled dosing available if you reach out and ask. Oh, and then a plug for our app. If anybody is interested in more helpful information, that QR code will take you to the app. It's free to download, and then you can go to Children's Colorado and access all of our recommended antimicrobials and guidelines and things like that. So put that there and then skip that and go to questions. Sorry, I know it's right at time.
No worries. Thank you so
Yeah.
much, Dr. Miller, for your wonderful presentation. You have a lot to cover. And as always, like without pediatric, this will never be enough time to talk about all these important interventions.